Hi, welcome to Cardiac MR Simplified at mricardiac.com. This is Dr. Bhavin Jankari, and today is my day. Before I start, if you would like to know each time I have a post up, and I also have posts at CT Chest Review and ctbiopsy.com, then this is my WhatsApp channel. In today's case, the 131st is titled When the Dilatation is Mechanical. So this 44 years old presented with dilated cardiomyopathy, and you can see here the diffuse severe hypokinesia. The ejection fraction was 23%. Here are the values of the end diastolic and end systolic volumes. Now, there wasn't much on the multiparametric imaging. T1 and T2 were relatively normal, nothing on stir, and no late CAT enhancement. But when we looked at the images, we found that there was severe aortic regurgitation. You can see the jet here on the LVOT views. There is dilatation of the aortic root, but somehow this had been missed on the echo. So the echo showed mild AR, but it didn't document this extent of severity. And when we uh, did the measurements, we found a regurgitant fraction of 67%. This is what the echo had mentioned, but clearly the patient has long-standing severe AR, which then on subsequent echoes was proven, etc. And this was the aortic root which was dilated. And so, if we summarize our findings, there is dilated cardiomyopathy, no edema, fibrosis, or scar, severe aortic regurgitation, and dilatation of the aortic root. So, let's spend a little time understanding what happens with chronic long-standing AR and the left ventricle. First there's volume overload, then there's progressive hypertrophy with increase in size, then you get a high afterload. And this lasts for a long time, many, many years. And then at some point, the LV fails with, and pressure overload as well. Then there's fall in ejection fraction and then symptoms. And I think the whole idea is to pick up the AR before the heart fails and then to repair it. Now, here's another patient who has a regurgitant fraction of 36%. EF of 37%, but see the extent of hypertrophy that we see here, unlike our first or index patient who has thinning as well. Now, this is a patient with a bicuspid valve, and you can see that here, who still now has a normal LV dimensions, no hypertrophy, and I guess that's only because the patient is just 26, and over a period of time, this will then worsen as well. And you can see here the eccentric AR jet with a regurgitant fraction of 41%. There have been quite a few papers in the last 3 to 4 years addressing all of this. And so there was this one paper that discussed the parameters associated with adverse events, and that's a regurgitant volume greater than equal to 47 milliliters, a regurgitant fraction greater than equal to 43%, indexed LV and systolic volume 43 ml per square meters, similarly EDV, the LVESD of greater than 4 centimeters, and an indexed LVESD of greater than 2 centimeters per square meter. Now, if you look at our patient, the regurgitant volume was lower than that mentioned in the list of adverse events, but the regurgitant fraction was higher, the indexed end systolic volume was much, much higher, the same with the indexed end diastolic volume. One parameter which I have never used that was mentioned was the LV end systolic diameter. This is how it's to be measured, and it was 49 millimeters as compared to the 40 millimeters cutoff. And then the indexed LVESD was 2.83. Clearly, this patient has many, many factors that suggest an adverse outcome, and our patient has presented late. There's been another paper, and you can see the reference here, summarizing the current evidence for surgical intervention, and you can just screenshot this and check this out. But basically, it is important to look at the ejection fraction and the LV and systolic diameter. And the moment you kind of start reduce, or when the ejection fraction starts reducing, or the LV and systolic diameter starts increasing, perhaps it's a good idea to intervene. Our patient was already considered high risk for surgery, met multiple surgeons, and then took a decision to go in for conservative management. And we just followed up with the patient who's fine 1 year down the line. So, in patients with dilated cardiomyopathy, we need to look at all possible causes, especially when it seems to be idiopathic. And so, while on this site we've addressed this multiple times and looked at everything from genetic causes to inflammatory etiologies to amyloidosis, etc. One is mechanical, an unrecognized AR or underdiagnosed severity on echo. And then once significant AR is diagnosed, it's important to measure the velocity using phase contrast imaging, as well as mention the various volumetric parameters, and these have to be indexed. And one parameter that I think as radiologists we're not very familiar with is the end systolic diameter, to be measured in the four-chamber view. Uh, the book that started all of this and available on Amazon and with Amazon Prime, that's my new book, again available on Amazon Prime. Thank you so much for listening to me, and have a great, great week ahead.